You're listening to a podcast developed and produced by the Association of Asian Pacific Community Health Organizations, AAPCHO. To learn about AAPCHO, its members, or the principles and values that have guided this organization's work for more than 20 years, please visit www.aapcho.org.
Accountable Care Organizations Improving Coordination of Care is AAPCHO's latest podcast series exploring the concept of accountable care organizations, ACOs, and their impact on community health centers and the patients they serve. Dr. Peter Shin is an associate research professor of health policy at the School of Public Health and Health Services at George Washington University. In this two-part episode, we listen in as Peter shares key findings from his research on ACOs and their potential impact on both providers and patients with AAPCHO's communications assistant, Beverly Quintana. What is an ACO?
ACO stands for Accountable Care Organizations, in which a network of providers operate as a single provider entity and is held responsible for the quality and cost of the care that they provide to assigned patients. So think of it as a special club where various members work collaboratively and share resources to promote better coordination of care and in return share in the savings that arise from better quality.
How did this concept of ACOs emerge, and why is it important now?
I think in general the concept and goals of integrated systems of care have always been around. Although the Affordable Care Act created the ACO as a unique provider entity, many of the features of ACOs actually share many of the features as capitated managed care programs that try to promote access to comprehensive and preventative health services. So it's not wholly foreign or new. What the ACO regulation does in terms of care delivery is place a much greater emphasis on care management and tries to better align incentives in way of shared savings with provider performance and quality, and also adds that population health element as being key to reducing costs. Unlike managed care plans, the ACO organization is largely organized by providers. So in a way, the ACO model allows providers to decide and drive the way they think care should be organized.
Why is this important for community health centers?
Assuming some of the challenges of ACOs are addressed, there are at least three reasons why it's important to the health center program. First, health centers are a medical home for 19 million patients, including 1.4 million low-income Medicare beneficiaries who face everyday significant barriers to specialty and other types of services. And given the focus of ACO regulations is to improve care coordination and healthcare quality, the ACO model represents a great platform for extending and building on their patient and community-centered medical homeness and efforts to really impact health disparities. Secondly, the literature consistently shows health centers are less costly than other ambulatory care settings, but don't really share in any cost savings they bring to the system. In fact, most health centers actually hire and effectively use care managers and care coordinators out of their own operating budgets. We at GW estimated using national medical expenditure data, which showed that in 2009, health centers saved approximately $24 billion for the care of 19 million patients then. And I mean, what health center wouldn't want to get some of that back to reinvest in care improvement? And lastly, and probably more importantly, it really does benefit their patients. And again, when we're talking about health center patients, we're talking about low-income and high-risk populations and communities where there's little or no options for getting health care, and a population that is considered hard to reach, hard to enroll, and hard to serve because of language, geography, culture, poverty, lack of other alternatives for care, and what have you. But that health centers have been very successful in really serving them. Greater integration with other providers and ability to reinvest any savings back into care for this population under the ACO and the shared savings program definitely boosts the quality and, of course, add to the future savings.
What are the biggest challenges or dangers for ACOs?
In general, a common challenge with most new initiatives is really the upfront cost of putting all the electronic billing and quality reporting systems in place, and in terms of time. I think folks are still unsure how much of it will really cost them to realign their systems to put new quality measures into their reporting process. And related to this issue is that the quality may not really be that accurate, since the ACO allows patients to opt out of reporting their data and can even access care outside the system. So there's a great degree of what ongoing costs and savings might actually be able to be calculated. The shared savings program also includes some risk, but I can't envision how we would design an accountable system of care with that one. The problem is that the ACO, again, allows patients to leave the system while still holding the ACO organization accountable for their health. But in relation to the health centers have a much bigger problem. As I mentioned, the proposed Medicare shared savings program effectively doesn't let health centers serve as a medical home for their patients. So what health centers would, again, want to participate. And even if they do participate, and since none of the patients are really assigned back to them, how would they actually be able to share in the savings? So without this being spelled out more clearly, this last challenge actually presents a significant barrier or disincentive for health centers.
This podcast was brought to you by AAPCHO. Please join the conversation on our Facebook fan page at facebook.apcho.org and tune in for our next podcast at www.aapcho.org.